Mark Rubin, Director of Bern Center for Precision Medicine and the Department of Biomedical Research, University of Bern, will now take the floor.
Thank you very much. And I'd like to thank the students, rector and president for a kind invitation to speak with you on your 10th anniversary. Congratulations. And honored guests. So today my assignment is to talk about precision medicine. And precision medicine is one of the many, I think, changing areas in medicine. We heard about AI, so artificial intelligence, but precision medicine has been around a little bit over 10 years. And I'm going to give you some examples today and try to define precision medicine, examples from the field, which I'd like to think of as the hard work we put in, different seasons, and we try to move forward. But it is hard work, and I think we have bits and pieces, and hopefully working together, I think we'll move forward in this area. So I have some disclosures, none are relevant for today. So is precision medicine? So as you are well aware, in medicine, we prescribe glasses that fit our eyes, and we give medication based on whether you're a child or an adult. It's very different. So medicine has been precise for a long time. Precision medicine is really taking into account other characteristics such as genetic predisposition, environment, lifestyle, and these ideally are taken all into account in defining a patient's treatment. The right treatment for the right patient at the right time. Very simple slogan or mantra for precision medicine, not so easy. This is perhaps the most important slide of the presentation. This is what we do in medicine. We try to use a taxonomy or classification of disease that we then make a diagnosis, treat individuals with standard of care that often has been developed through clinical trials, and then we try to improve health care. And where precision medicine comes in is that we really should be doing this in a dynamic way. And so we heard a little bit about the activities going on here. It's very important to implement basic science, translational research, information from the electronic health record, and how do we integrate this knowledge to improve all of these features? So better diagnoses, better treatment, and better outcome, and to follow this. And so I think the very important message is that precision medicine really should be thought as a learning system and a system that is going to integrate data in a dynamic way. A lot of different information comes into the system, so most of us think about genomics when we think about precision medicine, but there's a lot of data that comes in from research. Diverse populations are very important to understand how to best treat patients. Small data, and I'll tell you a little bit about small data in a moment. How do we work with healthcare providers to demonstrate that what we're doing is actually a better way to treat patients? It might be more costly up front, but might save overall. And so how do we do that? And then obviously taking into account patient data. The people working in precision medicine are a little bit different than the traditional doctors and healthcare providers that we usually have. So we have basic scientists, computational biologists, mathematicians, and there's a lot of ethical considerations. So we may have ethicists, we may have lawyers, and there's a lot of things to think about because of the costs and the implications of the healthcare system. So economists may play a role. So it's a constellation of a number of individuals that need to be involved. In traditional medicine, we think about one treatment for patients, so one treatment for all. And in precision medicine, we are trying to think about the best treatment. And here depicted are two physicians, but in fact, we need really a team of individuals to think about how to improve healthcare. This is also not only a local activity or a national activity, but a global activity. And there's some really important examples of nationwide precision medicine or precision oncology programs that I'll just give you a little bit of insight into. So these are just showing England, Finland, and Switzerland. I'll just give you a few examples. So for example, in Finland, They have looked at around 200,000 Finns, and they're going for 500,000. And they're collecting information from various biobanks across Finland, collecting data on outcome, types of drugs individuals are taking, death registries, and then studying 15 diseases in Finland. And what they're able to do is they're able to then say, these are the types of diseases we have, these are the genetic associations, these are the clinical associations, and then compare them with other databases. This is a playground for researchers, but it's also going to be very important as we move forward to ask questions about disease, predisposition for disease, and how we can prevent disease. In the 100,000 Genome Project in the UK, they have some very ambitious goals. Make genomics part of healthcare. So the NHS has decided they want to try to make whole genome sequencing part of healthcare. How to enhance the healthcare system with precision medicine. And can we uncover information in the UK that will be valuable for the participants? And so I think it's very important to also engage patients, and that's precision medicine. We hope that the patients will become part of the process. Very recently, the UK published on around 14,000 whole genomes that were sequenced in cancer patients, and the goal was to try to identify quicker ways to come up with more treatments for patients who were failing treatment. We recently reviewed this and summarize it, but I would just say that it's a new approach. There's a lot of requirements, analyzing the data faster. How do you get the data back to the patient and the clinician? And these are exciting programs. In the United States, where I originally am from, the All of Us program has a little bit different spin. Medical research hasn't always seen you. We're changing that. And so the idea is that we have a very diverse country, a very diverse population. How can we capture some of that information? Most studies to date have been done on white European males, and then maybe some females, but mostly on white Europeans. And so how can we have more diverse genetic information? In the study that we started in New York with Columbia and Cornell, we took advantage of New York's tremendous diversity. And so over time, this population is only going to change. More Asians, more Hispanics, and this population is valuable for understanding diversity. Most recently, just this past few weeks, the All of Us program published on their dashboard of information. This is publicly available. This is available to researchers to explore. And one of the exciting things about this data is that they've included a large percentage of people who are underrepresented in biomedical research. It's very important new data. They also are able to show discrete areas where different populations are different. For example, here is a European population, African American population, and Asian population. I think what's extremely powerful is the ability then to link this information, genetic information, with the electronic health record. And as you can see, over time, going from 2010 to today, it's gone from around 20% to now 60 to 70% of the individuals enrolled in the program have data that's connected to their electronic health record. It means there's a lot of information that can be correlated. So what are some of the challenges of precision medicine? It's a big investment, a lot of gains, but how can we evaluate what it's worth? So in a healthcare system, we only have limited amount of resources. There are a number of different diseases. We can't focus on only one disease. And the diagnostics are expensive. I told you about whole genome sequencing. These are expensive. They're becoming always less expensive. The drugs are expensive, sometimes up to €1 million for treatment. And some of the benefits may be tremendous, but others may be small. So how do we evaluate that? And that's where I think we have to think about bringing in economists and ethicists to evaluate that. Big data is obviously a very important role in our entire economy, but also for healthcare. And so how do we deal with the data that's coming, the less expensive whole genomes, under €1,000 for a whole genome, and now we can generate enormous amount of data. And we heard about AI, so we heard about artificial intelligence, the number of parameters is exponentially growing for artificial intelligence. How are we going to deal with all that information in biomedicine? I'm a pathologist by training, and just to give you an example, in pathology we deal with images. So artificial intelligence or machine learning was first established when somebody asked the question, can we take an image of a cat and distinguish it from other animals? And that's where it really started, and they demonstrated that, and that was a major success. So now in pathology, there are approved tests that can use artificial intelligence to identify cancer. And so what's the future of that? What's that going to look like for pathology or radiology or other areas? So initially, it's going to assist, and these systems may be very expensive. It's going to also make it more democratic process. So you don't need to be the world's expert in prostate cancer, for example, to make the diagnosis. You can use a system to help you. And then what many pathologists fear is that we will be entirely replaced with a robot or something that can do the job better than we can. But I think all of this should be embraced, because the idea is that we're going to come up with better ways of diagnosing and treating patients. A few comments about small data. So where are you right now? What did you buy this morning? Where have you been? And where are you going? So we share this information all the time with different providers, and all of us have different levels of concern. But are you worried about this data? I think many of us are, but it also has benefits. So if you like watching movies or Netflix, they tell you what the next movie or TV show you should watch. Spotify, the same thing with music. And if you're using Google Maps, it's also going to tell you where you should go to shopping or what restaurants. So it's a problem that we have to think about. It's a dilemma. It may have concerns for privacy, but it also may have benefits. And for biomedical research, it may have important benefits for society. So I told you about All of Us, and just a week after the publication came out with this beautiful genomic study, there was already controversy. So I showed you the image of these different discrete areas, so Caucasian, Asian, African American, or Hispanic populations. This information has already been misinterpreted as thinking that all of these ethnic groups or racial groups are totally separate, and leading into racist type of thinking. And so it's very important in our communication of this type of data to make sure that we explain that this is a continuum of data, and we're only emphasizing some discrete differences. And so I think this is very important that in our ability to communicate results, we make sure that everybody understands what we're emphasizing and not to fall into traps that lead into theories that are just basically not true. So to wrap up the first part, I wanted just to emphasize that precision medicine should be a continuous learning system, that we need to integrate this data into the daily care of patients, and that this will allow us to individualize for individual patients. But I think most important, the bedside and the basic science that goes into precision medicine, the findings will lead to improved training, education, and care over time. So I think that's a very important concept for precision medicine. So I entitled the talk Lessons from the Field, or Fields, and so I'm going to give you 3 examples from the fields of precision medicine to hope to give you a little bit of the scope of precision medicine. By no way is this all-encompassing. So basic understanding leads to new treatments. And I think one of the most important concepts is that we really need basic science, translational science, to help us come up with new treatments. So if we look at a normal cell and a tumor cell, they're very different. Normal cells, when they undergo DNA damage, they repair themselves or they undergo a programmed cell death. This is normal because they don't want to replicate a DNA that's not fixed. Tumor cells have found ways to get around this. This allows them to continue to grow even if they have DNA damage. I'll give this as one example. Now, this is not a New York City subway map. This is the DNA damage pathway simplified. And what you'll notice here, next to all the genes that are involved in DNA repair, which is quite complex, you'll see a list of different drugs that are being developed or have been developed for targeting DNA damage. It's extremely important in cancer and other areas because it's believed that by targeting DNA damage repair systems, we can attack cancer. But there's challenges, obviously, with this, and one of the observations is that if you can attack it in two different areas, or if you can attack cancer in two different areas of this DNA repair, you can take advantage of the backup systems that have been developed to protect cells. So I just give the example to remind us about how important backup systems are. So when Captain Scully and his first officer were flying the United Airlines plane, and the two engines died. They needed to land the plane in the Hudson River in the cold weather. They had a backup engine. Not many of us are familiar with this, but there is a backup engine that lets you start the engines, but also power the plane. They were able to use the backup engine to power the plane and land it in the Hudson. So backup systems are important. And scientists have been studying yeast, where there's only 6,000 genes, flies and mice, to understand this DNA repair mechanism and understand that there's, yes, redundant engineering, so there are backup systems, but how can we exploit that? And scientifically, it's called synthetic lethality. The idea is that you hit two areas. So, for example, if you have two proteins that are quite important in DNA repair, and you hit one, there's a backup system. And if you hit the other one, the backup system takes place and can keep the cell alive. But if you hit both, it leads to cell death. So this is the concept of taking advantage of redundant systems, identifying them scientifically, and then attacking them. And Lord and Ashworth, as I've depicted here on the right, and others have identified a gene called PARP, which is one of the DNA repair genes that play an important role in this mechanism. So how do you put this into practice? I'll just give you an example. So this is over 10 years ago, we started a precision oncology program. And in this program, we looked at men with advanced prostate cancer, but it could have been another cancer. And we asked the question, what treatments should they get after they failed the common treatments that are available? We performed genetics after metastatic biopsy, so we performed genomics and RNA transcriptomics on all the cases, and we asked the question, what alterations do they have that we potentially could treat? And in this study, we found that they had very common DNA repair mutations. So that was what I wanted to tell you about today. So they particularly had mutations in genes called BRCA1 and 2 that are very important, and you may be aware of them because there's some hereditary diseases where people are born with BRCA1 and 2, and they're susceptible to breast cancer, ovarian cancer, and other cancers. In fact, in this study, we found that up to 30% of the men with advanced prostate cancer with no prior history of hereditary cancer had these genomic alterations. And so the concept would be that PARP, the protein that I told you about, sets out a flag. If there's a damage in the DNA, like a single strand break here, PARP will then call in the DNA machinery that fixes it and repair it. If PARP is inhibited with a PARP inhibitor, so this drug that I mentioned, what happens is it can no longer be repaired. The cell undergoes duplication, and now you have a double break. So in the normal setting, it would be repaired by the backup mechanism. But in these individuals with prostate cancer or with hereditary disease, where BRCA1 or 2 is altered, they can't repair it. And so the cells, the tumor cells, would undergo death. So the idea was to look at trial data where patients have been treated with PARP inhibitor and ask the question, what was the DNA look like of their tumors? So Johan de Bona, who's depicted here at the Royal Marsden ICR, was leading this in the UK. And when we retrospectively looked at the data, we found there was an increased number of DNA repair genes that were altered in those who responded. And then moving forward, he proposed a phase 3 clinical trial where he asked the question up front, let me identify patients who have these DNA repair mutations in BRCA1, BRCA2, and other genes, and ask the question, do they respond better with drug? And in fact, they did. So this is an example where understanding the basic biology from yeast and flies and mice can allow you to design trials and drugs to exploit a weakness and do this in a precise way by identifying the patients with the mutation who would best benefit from the drug. But I would emphasize that it really required an important investment in basic science, and so I think that's quite important to remember. Just two other brief scenarios. So first, how can precision medicine help with pain? As a medical student in New York, we went to Harlem Hospital and we took care of a clinic where patients were coming in with sickle cell anemia and they were being treated. And these were young African American children who would rather be playing outside or be in school than be in a hospital. And unfortunately, if you have sickle cell anemia, you often have crises that are brought about by cold weather, stress, activity, along with a number of other medical symptoms. And this is due to the fact that you have, instead of normal biconcave red blood cells, in times of stress, the red blood cells change their shape. And the effect is these sickle red blood cells can't flow nicely through the vessels, but instead get stuck in vessels and cause what's referred to as vaso-occlusive disease. And this is very painful for the children and the adults that get this. This disease is due to a single spelling error in the DNA. And this spelling error leads to the sickling. It's believed that the reason for having this is that it protects against malaria in Africa. But unfortunately, if you have two copies from your mother and father, you are a disease trait carrier and therefore have sickle cells. So very recently, there have been a number of attempts at different therapies, but very recently there's been a really exciting breakthrough, and that is using DNA editing technology, CRISPR-Cas, to knock out this defective base and then create a new blood cell that actually doesn't sickle anymore. And this is extremely exciting. And here's the New England Journal paper that described what happened. So after treatment with this new approach, up to 50% of the blood cells that were circulating the patients after treatment were now normal. They weren't sickling anymore. And if you look at the individuals here before, every red dot, so all the rows are patient, every red dot could be a visit to the hospital or an extremely painful event. After treatment, in yellow, you see hardly any red dots, meaning that these patients are almost completely cured. This is only 3 years, and so obviously we need to see what happens over longer time. But patients going from a debilitating disease to one that they're potentially cured. And for those of us with young children, we know the children would much rather be in school. They don't want to be in the hospital. Parents don't want to be taken to the hospital. And they want to have a wonderful life. And so hopefully this is one way that that can happen. I would just note that this is not an easy treatment. So what we hope is that we bring normal activity back to these individuals with sickle cell, but the cure is costly and it's complex. The patients have to undergo bone marrow biopsies to get the material, to harvest the material that has to be DNA edited, and then they have to have their entire bone marrow ablated and then re-implanted. So it's quite a complex procedure, but obviously one that can be entirely curative. And the last very brief scenario is how can ancient DNA, so DNA as old as 40,000 years, help us understand disease? So there's a recent article about how looking at ancient DNA could give us insights into multiple sclerosis, a very different disease. So in this disease, it's an autoimmune disease. The immune system attacks nerve cells throughout the body. And this is obviously extremely debilitating. The causes for multiple sclerosis are multiple. They're believed to be environmental, lifestyle, and genetic factors that play a role in having the progression of multiple sclerosis. There are some risk factors that have been identified. There's also a very interesting observation that in Northern Europe, for example, it's much more common than in Southern Europe, and there's a lot of speculation as to why that occurred. So in this study, they took DNA from different groups that were collected by archaeologists, and the bones were then probed and DNA was extracted. And so looking at different populations or different groups, so hunter-gatherer populations from 40,000 years ago, and then farmers and pastoralists who are animal herders from 10 and 4,000 years ago, who settled in different areas. So for example, just to show you, the farmers are more in the south part of Europe, and the herders are more in the northern part of Europe. And what they found is that one of the known risk factors for multiple sclerosis tended to be seen more in the individuals who herded animals. And this image shows you today the frequency of multiple sclerosis, and this shows you then where the herders were, the ancestral herders were in red. So the cases almost overlap with where the herders were. And then, in addition, they looked at an interesting and important feature, which is that when were domesticated animals brought into these populations, and they can see that it directly correlated with this risk gene that has been identified with multiple sclerosis. So this risk gene has an awful name, but this HLA gene puts you at 3 times greater risk of having multiple sclerosis. So why do you have it? And so one speculation is that as in times before antibiotics, so 10,000, 4,000 years ago, where no antibiotics were present, it was beneficial to have an immune system that was upregulated to protect you from bacteria that were associated with the animals that you were in regular contact with. And perhaps in those days it was beneficial, but subsequent to modern lifestyle, it's no longer beneficial. But these individuals from this population still have this risk allele that puts them at higher risk for an immune system that's upregulated. And so while it doesn't have a cure, it suggests some understanding to what are the risk factors for the disease, and allows us to then target using ancient DNA and comparing it to modern DNA. So I love sports, I love riding in the mountains, and we know that's a challenge. It's a personal challenge. It's one you have to face with great discipline in order to be successful. Maybe you don't win, but at least you finish. And so I think the same thing with precision medicine. I think we're going to have to focus on areas that we can make success. We have to be disciplined, and we have to remember that this is not a short race, it's a long race. So today I brought you some concepts about precision medicine, how discovering vulnerabilities in cancer may be extremely important for treating cancer, how new knowledge from ancient DNA could be helpful, and that could also be considered precision medicine, and how thinking about bold therapies can cure kids with sickle cell anemia, but also others and other diseases to be thought about. So thank you very much for your attention today.